Dr. Smith, how are we doing?
We're busier than a one-armed paper hanger.
Oh my goodness, I love it. I love it. We're gonna give folks probably just a couple more minutes to join in, and we'll go ahead and get started in just 2 to 3 minutes.
Awesome.
Perfect.
Oh boy, yeah, we're just swamped today.
Hey, that's always exciting though. That's always exciting.
I'll take swamped over crickets chirping.
That's right. That's right. Always better to stay busy.
Well, I'm really excited about this.
We are too. We're one. I mean, again, just super excited to have you on. I know that you have a pretty amazing story yourself. So, and we're right. I mean, we're right here at 9 o'clock. So we can, why don't we go ahead and kind of just jump into things, if that sounds good to you.
I'm by me.
Perfect. Well, hello, everybody. Thank you so much for joining us on the Patient Partner webinar series focusing on bariatric surgery. My name is Patrick Frank. I'm one of the co-founders of Patient Partner. And, we just have so much information to share with everyone today, and we're really looking forward to it. We are lucky enough to be joined by Dr. Adam Smith, who is going to be really our host for the webinar. And, guys, I cannot tell you enough how amazing this man is. I mean, he has such a blend of the personal side to this story, but also, the professional side that he brings to the table. And he'll be talking so much about the misconceptions surrounding bariatric surgery. And let me tell you, I mean, you can listen to the guy and you can trust him because he was named one of the top docs in 2021 by Living Magazine in all of Fort Worth. So, I think it's one of those things where we are so lucky to work together with folks like Dr. Smith. And we couldn't be more excited to have him on today. But before I make that official introduction, I just wanted to tell everyone just a little bit more about, exactly what Patient Partner is, and what we're doing. And that is that, we are building a community, for patients, by patients, and purely for the mission of giving back through relatable experiences. We provide the opportunity for future patients to connect one-to-one to other individuals who have already been through the exact same surgery that you're contemplating. And who are these individuals that you're speaking to? Well, simply put, they're recovered patients. They're mentors. They're your partner through surgery that is able to be there to answer the personal side of questions that you have and to be able to really help you, be accountable throughout your healthcare journey. And there are 100% volunteers who are donating their time purely to give back and share more about what their experience was like to you. And so we're going to be talking about a whole lot and really focusing in on the misconceptions of bariatric surgery, because there are so many of them. One, you still need a blood pressure medication and insulin. Recovery is painful and takes too long. Weight gain is inevitable and there's nothing you can do about it. And you don't have to make any dietary changes after surgery, and that your personal relationships are going to stay exactly the same after surgery. These are just some of the many misconceptions, but definitely the ones that, after engaging with our patient community and patients every single day, we have heard time and time again that are the most prevalent in conversation and in their lives. So again, throughout the webinar, please feel free to chat us and send in questions that you have. We're going to try and answer as many as we can. Throughout the webinar, at the very end, we have a Q&A section where Dr. Smith is going to be able to answer those for you. But, again, I want to just kind of take a step back now and make this handoff to Dr. Smith. One more bit of introduction to him. I mentioned earlier why we are so lucky to have him here is because he has this unique blend of both this personal experience of actually going through bariatric surgery, but at the same time is one of the top surgeons around. And, I think it's one of those things where you're not going to be able to find this type of perspective really anywhere else. I cannot tell you, how rare it is to have someone who sees both sides of it and is able to speak to it on both levels. And this knowledge has really helped him develop one of the most comprehensive aftercare programs after actually going through the surgery. And so again, I'm going to take a step back. I want to, let Dr. Smith take the reins here. Thank you so much for joining us again. Anything else that I may have missed?
I think you got it covered. I really appreciate being able to be with you guys today. I love the concept of patient partner, and if you don't get anything else to take away from today, is that nobody can go through this journey by themselves. We need a friend, a mentor, a companion to walk this walk with us through this journey. The surgery is the least important part of the process. Getting through it and lifelong maintenance is the most important part.
Absolutely. Absolutely.
So I'm going to touch briefly base about bariatric surgery requirements before we get onto the misconceptions, because one of the most common questions people have when they call up is like, well, am I big enough? Am I sick enough? Do I qualify? Will my insurance cover it? What do I have to do to get this tool that I need to help me make a permanent lifestyle change? Now, I'm not going to get on a soapbox about how we came by these requirements, because there's a lot of us in our field that believe that these need to be looked at or relooked at, but this is what we live with now. And as a general rule, and there are exceptions to every rule, every insurance company is different, even there are regional differences. So don't take this as gospel. You need to contact your own surgeon, if it doesn't happen to be us, to go specifically what the requirements according to your insurance, your area, and those things are. But generally speaking, if you're blessed and fortunate to be healthy and just overweight, your body mass index, which is a relationship of your height and weight, needs to be at least 40. Or if you're whatever a standard person is determined to be, 100 pounds overweight. If you're 5'1", you don't need to be 100 pounds overweight to have surgery. If you're like the rest of us, more mortal humans, and because you're heavy, you have health conditions related to your weight, then that entry level body mass index goes down to about 35. So there is not a top BMI limit for surgery. Obviously, the higher your body mass index is, sometimes the more aggressive surgical options there are, but it ultimately comes down to a personal choice. This can't be one of those situations where you wake up one day and say, I think I'll run out and get a gastric bypass today. Okay, you have to have fought the fight like we all have. You have to have done the diets and joined the gyms and taken the supplements. And Lord knows we've all done them all. And we've all lost hundreds of pounds only to regain them over time. So you have to have made the attempt. You have to have fought the fight. And your BMI has to be a certain limit to meet insurance criteria, Medicare criteria, whatever criteria for surgery. And we'll go on to the next slide. So let's hit those misconceptions. Okay. Here's a big one is well, you can lose weight, but you're still going to be diabetic. You're still going to be hypertensive. You're still going to be this. You're still going to be that. Most of our operations don't just cause you to lose weight. This isn't just about losing weight. In fact, our specialty society changed their name a few years back. It used to be the American Society of Bariatric Surgery. It isn't that anymore. It's the American Society of Metabolic and Bariatric Surgery, metabolism. When we do a weight loss operation, it changes the way your body works. So it helps with your body chemistries. Now, each operation does it in a little bit different manner and a little bit degree of aggressiveness. But every operation we do isn't just aimed at causing you to lose weight. It is aimed to help you change your relationship with food. It is aimed to help you change your lifestyle, but it's also aimed at directly attacking those health conditions that are making you sick. 80% of our patients, generally speaking, with diabetes, go into remission. Now, you can make the philosophical argument once a diabetic, always a diabetic. For me, if I get you off your meds, I'm happy. Okay. If I get your A1C down to 5, I'm happy. Hypertensives usually get off a lot of their meds, but if you've been hypertensive for a long time, your family practice doctor, primary care internist, or nephrologist may still keep you on an ACE inhibitor or a 1 pill a day kind of regimen just to be renal protective. The biggie, and this one hits really home for me, is 70% of people with sleep apnea can get rid of that CPAP machine. And if you have sleep apnea, you know what I'm talking about. Those machines are a pain in the rear. And they're not just a pain in the rear for you, they're a pain in the rear for your spouse. You know, hooking up to that snorkel thing that covers your face and straps on real tight just to be able to have a good night's sleep and feel good the next day. It's necessary, but it's no fun. The good news is with significant weight loss, you can get rid of that machine. In fact, I just use a little dental guard because I still used to grind my teeth. And so I do it more to protect my teeth than to treat my sleep apnea. I got rid of that machine, and that was one of the best days of my life when I didn't need a CPAP machine no more. Here's another misconception. You know, recovery is terrible, recovery is painful, takes too long. Our past follows us for a long time, and that is no different in surgery. When we first started doing bariatric surgery back years ago, you know, people had huge incisions and they had wound complications, and we really didn't have the techniques and the methodology, and we were just doing the surgery. We didn't understand how important the comprehensive process and program was. So we had some bad outcomes, and those have haunted us over the last few decades. With the advent and the revolution of laparoscopic and minimally invasive surgery, our outcomes have improved. Our recovery times have shortened. Our complications rates have gone way down. And a lot of that is due to technology, but a lot of it is due to our specialty society that sets national standards. Most of us that are in center of excellence facilities, we enter all of our data into a national database, and we benchmark our outcomes against every other practice in the country. So we know that we're doing a good job. We don't just think we are. We know where we are in relationship to someone on the East Coast, someone on the West Coast, someone up north, someone way down in the Southeast. So most patients that have weight loss surgery, be it a sleeve or a bypass or a D-switch or even a band, some are even done as an outpatient now. You come in and you go home the same day. A lot of them spend one night. Some people spend 2 nights. It's rare for us to have a bariatric patient that spends more than 2 nights in the hospital. We usually see our patients in the office within a week, at which time if they're a sit-down job, like working at a computer, working in an office, we let them go back to work in a week. Now, we have a lot of patients here in Fort Worth. Literally, my office is across a highway from Union Pacific Railroad, and we have a lot of railroad dudes. So if you're a railroad engineer, you're not going back to work in a week, let me tell you, because you're not going to be crawling under a box car or a freight car after 1 week. But probably in 3 or 4, you're good to go for a hard, heavy lifting, tough job. The other thing is, oh, you're going to be on liquids the rest of your life. No, you're not. Usually you're on liquids, and every doctor's practice is different. So don't take what I'm saying as gospel or everyone does it this way or they're messing up, because we all have our own protocols and standards, and everyone tweaks their program to fit their patients. And not every patient has the same post-op recovery, even in our practice. But generally, you're back to foods that require teeth within 2 or 3 weeks. Usually kind of liquids for a week, pureed for a week, and then we call it chew food, food that requires teeth. Exercise, we let you start as soon as you feel like it. Your body is a very smart thing, and it'll tell you if you're doing something wrong. It's called pain. And if you're not having pain, you're probably okay to do what you're doing. Now, we do restrict you from like high impact, heavy lifting, things like that for 6 to 8 weeks. We start slow, we go slow, we build up, we listen to our body, and we listen to our surgeon. So here's number 3, misconception number 3. Oh, you're going to have this surgery and your weight's just going to come back in 5 years. Not true. Can a human being overcome anything we do for them to try to help them? Of course. We see that in every field of medicine. And there is a small percentage of patients who will regain some of their weight. It is very rare that we see someone that gains all of their weight back, but there's a small cohort. How can we prevent this? Follow-up. When you're not doing follow-up, you do more follow-up. Support group. This is where the mentoring program is very, very valuable. All of us need somebody to encourage us when we're down and to hold us accountable when we're being naughty. We're human beings. We make mistakes. And having someone that's there for you that will say, that will tell you that there's a log in your eye is good. But you also need someone that picks you up when you got the blues. We're all capable of getting the blues from time to time. And we need that help because this journey is not easy. It might be the hardest thing you ever do in your life. You need someone there to help you. Some of us do that online, especially younger folks. Some old geezers like me, we got to have face-to-face contact with that mentor to keep me on track. If someone isn't right in my face, then I assume I'm okay, and that's not always the truth. But a majority of patients that lose a significant amount of weight are going to keep it off. And how much you do and how well you do is dependent on how willing you are to change your lifestyle. And I'm going to tell you, if you think you can go out and have surgery and don't make any effort whatsoever, you should wait, because you have to be committed to changing your lifestyle if you're going to make this thing work for you. Next one. Misconception number 4. Oh, I don't need to make any changes. I have the surgery and I wake up the next day and I'm skinny. Doesn't happen. If you're counting on that surgery to do everything for you, you need to think again what you're doing. Because the one thing we don't ever want to have is someone that has something called buyer's remorse. We don't want someone that undergoes surgery and a year later wishes they had never had surgery. People have misconceptions about people that are having surgery, and we'll talk about that in a minute. But when you have, most of our surgeries are designed to make it easier for you to make a permanent lifestyle change. Some of them are more aggressive than others at forcing you to make a lifestyle change. But if you fight it and fight it and fight it, you're going to suffer. So we generally focus on healthy, lean proteins, and there's exceptions. So don't substitute this for medical advice. You need to talk to your dietitian or your surgeon for exactly what's right for you. But generally, lean, healthy proteins, we eat those first. And then if we still have a little bit of room left or a little bit left to go, then we go to our complex carbohydrates. Now, there's another word for complex carbohydrates. They're called vegetables. Those are things that we don't see a lot of in fast food and prepared food. So you will probably want to consider some meal planning once you undergo surgery. And that's something to be prepared for in the preoperative process also. We're not putting you on some crazy keto diet or something. I don't want you drinking a milkshake with a stick of butter in it to try to drive you into ketosis. We just want healthy protein, complex carbohydrates. The other misconception, oh, you're going to be on 100 vitamins the rest of your life. Now, we do monitor your what we call micronutrients. That's another word for vitamins and minerals. Certain surgeries require more vitamin supplementation than others. In particular, like our duodenal switch patients, that surgery by design makes it hard to digest fat. There are certain vitamins that require fat to be digested, vitamin A, D, E, and K. So we monitor those very carefully, and you might need additional supplementation for those. Most of our bypass or sleeve patients, a high quality bariatric quality multivitamin is usually enough. Postmenopausal females, sometimes we really are very aggressive at the vitamin D and the calcium levels as well, but not taking a fistful of vitamins like we used to have to. So we discuss every human being is different, and we use online resources as well as having 2 full-time registered dietitians in our office to try to customize each individual's needs with their plan. So we don't just hand you a book and say, here, follow the instructions. We try to custom tailor that to each individual's needs. And those are discussed before surgery, during surgery, after surgery. And I kind of sometimes chuckle. We have a private Facebook group here in the practice. And at least once a month, I'll have someone come on there. Nobody told me what to eat this week. It's like, maybe not. So education before, during, and after surgery is critically important. All quality programs do this. This is not unique to us. Now, I'm proud that we think we do a really good job at it, but most good quality center of excellence qualified bariatric programs are going to do this for you. Next. Personal relationships stay the same after surgery. And this is something that we have to address before surgery. And we look at this from multiple angles. Unlike any diet you've ever done, and unlike any part of your life, people feel compelled to butt in to what you're doing from a weight loss perspective. You know, in the US, we don't discriminate on gender, race, ethnicity, religion, anything. Whatever you do, we're not supposed to discriminate against that. But people discriminate against people that are overweight every day. You know, chairs you can't sit in, restrooms you can't go in, airplane seats. That's a problem. And if you're not ready to deal with that, you're not ready for surgery, because that changes. And you may, and I think everyone has this, I call them saboteurs. It might be a spouse, a sibling, a parent, a relative, a coworker, that number one, oh, you didn't need that surgery. You just need to do my diet, or you need to join my gym, or you need to go here or go there. You didn't really need that surgery. Well, yeah, I did, because I've been trying to lose weight for 25 years and can't keep it off. And they'll judge you for having this surgery, and you need to have a response for that. And that's where having a mentor or a friend or a go-to person is useful. When you're under that stress and you're getting pressured about what you're doing or judged about what you're doing, it's good to have a friendly face there to help you. One of the most common things I hear is, are you sure you can eat that? When you've had weight loss surgery, all your friends are automatically experts on bariatric surgery. So, are you sure you can eat that? Well, I just did, and I'm not dead. So I guess I can. And then there's the person that gets threatened when you lose weight. So you start losing weight, and someone that's a friend of yours that's kind of been a couch potato maybe with you or whatever, and then you're wanting to get up and go do things and they don't, they get mad. Sometimes they get jealous. Sometimes they get paranoid. So it's important to be prepared, because A, if that person isn't willing to accept the changes you're making, maybe so that they understand what you're doing. We really try very hard to identify that early on so that we can prepare and guard for that. But when we identify it in our patients, we try to intervene. Next slide.
And so I know one quick thing. I know just a quick change up in you know, kind of the order of things. I know Victoria was supposed to join us today, and unfortunately she had a family emergency. But as I mentioned on the beginning of the webinar, Dr. Smith, I mean, standing up and being able to share your personal story with weight loss surgery, I think is a very, very unique opportunity for everyone listening and watching to really learn about, because, you know, as you guys can all tell from all the information that you just gave us, which is, you know, not only just so detailed, but you really correlated you so well with real life experiences. And that's because you've actually been through it. And so I just wanted to let everyone know that, and again, you know, kind of hand it right back up to you to share that, you know, your own personal story with everyone as well.
I'll be happy to. You know, we all get to this decision point in different ways. You know, every one of us has a unique story. It's a great, you know, it's a story of triumph and tragedy. I was not a big kid. I was actually kind of a skinny kid. I was only about 150 pounds when I got out of high school. And probably by the time I was out of college, about 180, 185. Time I got through medical school, about 200, 210. By the time I finished residency, about 245, 250. And by the time I'd been in practice 10 years, I was pushing 300. I was like 285-ish. And I had sleep apnea, I had back problems, I had plantar fasciitis, and some people would say I had a generally disagreeable disposition because I felt bad all the time. And I was already doing bariatric surgery. I started doing bariatric surgery in like 2000, 2001. And after about a year of it, number one, I noticed that I was operating on people that were my size or smaller. And there are certain things that drive you to considering surgery. And 2 or 3 things happened to me. You know, I'm a slow learner. It took me a while to wake up. I went to a hernia course, watched these dudes do surgery, and then we go sit in their office while they were getting another patient ready. Then we go watch them do surgery. And I'm sitting there in their office. I'm in a rocking chair. And as you'll know, my desk chair rocks. I love rocking chairs. But the guy came in the office and he asked me to change where I was sitting because it was an antique. You talk about having your feelings hurt. That sucks when that happens. And it's like, ooh, that's embarrassing. And then there were other little signals that happened to me along the way. That really wasn't very much fun. And, you know, I didn't tell these guys in the prep session this. I just thought of it is in my medical school yearbook, there were comments under things that other classmates had said. In my yearbook, someone said something about, I think I'm going to go get a sandwich. So people kind of made fun of me. I let it run off my back like water off a duck's back, but it really did over time hurt my feelings. But I think the final thing was, and it's funny, I had a person in the office today from the same town this guy was from, a guy that lived about an hour and a half east of here, called me on a Friday afternoon. And if you're a surgeon, you never get good news on Friday afternoon. So he called me up and I said, what's going on? What's the problem? What's going on? He said, I just want to tell you something. I tied my shoes for the first time in 10 years today. And I said, I couldn't remember the last time I wore lace-up shoes. It's like, dude, you got to do something. My grandmother was the oldest of 11 children, and she was Native American. She's Chickasaw. And they're all overweight and diabetic. And if you're a Native American and you're overweight and you're diabetic, you are 7 times more likely to have a stroke or an amputation than a regular Caucasian. And I was headed full speed ahead for that life. And I said, I've got to do something. And I was terrified. There was no one more terrified of me. I was terrified that I couldn't handle it. I was terrified I'd have a complication because I didn't trust nobody to operate on me but me. And I had to give up that control. Oh, that was terrifying. But I did it. And I had the surgery. I lost about 100 pounds. I've put some back on over the years. I had my surgery in 2002. So 19 years ago. But I'm still only on basically vitamins. I don't take any blood pressure medicine. I'm not on CPAP anymore. My back is great. I feel good. I had my feet get sore if I work more than 8 or 10 hours standing on my feet. But if I have a normal day, nothing. But my biggest challenge was accepting the fact that I needed help, that I had done it all, I had tried it all, and I needed more help. And why do I recommend having a mentor? You can't do this by yourself because you will have down times just like the good times. And anyone that thinks that having weight loss surgery is easy way out is a fool. It might be the only way out, but it's not the easy way out. And we actually looked at this back. I used to be at UNT for 10 years before I went private practice. And we said, why do some people do better than others with weight loss surgery? And we looked at different factors. And the only thing that stood out was that people that had support, whether they attended our in-person support group or whether they had a mentor that was going through this at the same time as them, or now, I mean, we didn't have all of the social media back then when we studied this, but having a mentor or a companion for this journey increases your likelihood of being successful, dealing with those personal challenges that are going to happen, accepting the fact that you've changed your lifestyle, and sticking to the plan. That is where the patient partner mentors help us. That's where we need whatever works for us to give us help. So my biggest challenge is getting frustrated. The first round of holidays were very hard for me. Some of my family members didn't accept the fact that we needed surgery. And in fact, I have a sibling that probably needed the surgery that's got end-stage diabetes and renal failure now. And that was his choice. But it's hard. No one can do this by themselves. It takes a team. I guess I'll leave it there.
That is, again, it's such a rare thing to see both sides of the coin, not only to go through it, but go through it with other individuals as well every single day and be a part of their journey. And I think that that's, so much about what makes, the experience with you, very unique is that you understand that, as you mentioned at the very beginning of this webinar, that the surgery is not the most important part, right? It's the entirety of the journey. And it definitely can be seen through, how you speak to it, and the level of insight that you have and you've shared with us today. I know that you've definitely talked through a lot of these in some in more detail than others, but these are, guys, these are the questions that were sent in at the time that folks had signed up, and some of them, even that we've received as the ongoings of the webinar. So we wanted to, put these out there, and Dr. Smith, if you could, address, some of these, that would be super helpful to the folks who have tuned in. And yeah, so I know that maybe we've gone through a couple of them, but would love to, to highlight any of these that maybe we can shed a little bit more light on.
Could be happy to. Top one, part of the food restrictions post-op, we kind of went over what we generally do in the early post-op period, but long-term is we're cutting out prepared foods. We're cutting out time, what I call time wasters. And that is like chips, cookies, crackers, sweets. simple carbs, simple starches, those are the enemy of the weight loss patient. We want healthy proteins, healthy carbohydrates. Those are the long-term food restrictions. That leaves you 90% of the food out there that you can have in moderation. What are conditions that might prevent someone from being a candidate for surgery? Number one, we like you to have a reasonable expectation to live another 10 years. Like if you're 82 years old, this is probably not a good choice for you. If you're 60 years old and your parents live to be 80, this is probably a good choice for you. As long as you can survive the surgery, that's number one. You're right. We don't want to throw the baby out with the bathwater, so to speak. Number two, you got to be ready. It has to be the right time for you. You have to be willing to change your lifestyle permanently and accept the conditions that come with that. And you have to have tried everything and be ready. Number three, we see this in the office. This is one of our biggest challenges in the office to deal with is I'm gaining weight post-surgery. What are some of the reasons might be happening? Well, we're humans. A human being that is determined to destroy their health will succeed one way or another. So is there always a behavioral component? Yes. But these surgeries are really designed to just be a tool for you. And their peak effectiveness happens in the first 12 to 18 months. If you haven't used that, what I call golden period in the 12 to 18 months to really make those lifestyle changes, there is a chance that you can start creeping back up in weight. Sometimes there's an anatomical component. Sometimes something has stretched. Sometimes something's different. Something else has entered in that alters your ability to be active. So we have to look at the whole person, the whole picture, anatomically, and to troubleshoot and then intervene if people are having any regain. Fortunately, it's not that common. Most people hit their goal and stay within 5 or 10 pounds of their goal for most of the rest of their life. Most common risk factors, this is like complications can occur from any surgery. Fortunately for us, they're pretty rare. In fact, we looked at this surgery with gallbladder surgery and knee surgery as far as life-threatening complications. And bariatric surgery had a lower percentage of life-threatening complications than either knee or gallbladder surgery. But bleeding or infection, which can happen with any surgery. You can go and have a cataract and have a major complication. So there is no things unique to the stapled procedures, which would be bypass, sleeve, or switch, are a leakage from that staple line. Fortunately, we're able to deal with those endoscopically most of the time now, so it doesn't always require a trip back to the operating room. People that don't eat right can have dumping syndrome or diarrhea or vitamin or mineral. If you don't do what you're supposed to, you can have metabolic consequences. Fortunately, that's also pretty uncommon. And last but not least, some people, especially sleep patients, can get heartburn after surgery, which we have to address and deal with. Which surgery is right for me? That's something we deal with every day. We have to balance our weight loss goals, our medical needs, and which surgery works for me. So there are general rules, but they don't apply on an individual basis. We have certain operations that are better for our diabetics than others or quicker. We have certain operations that are better for our really, really high body mass index patients, although there's an exception to every rule for that. There are certain surgeries that are better for our lower BMI patients or lower body mass index patients. So that's something you have to do one-on-one with your doctor, because we got to look at the whole person, the entirety of the picture to select the right tool for our journey. what's the pain level after surgery? That's just as dependent on the patient as it is on the operation. All of our operations are done laparoscopically or small incisions, and most people are off their pain medicine by the time they do their 1 week visit. But if you've been on pain medicine for the last 15 years, you're probably going to have more pain than someone that hasn't ever taken a Tylenol before. How much weight will I lose with surgery? That depends on where you start, your individual metabolism, and which surgery you have. Certain operations have a higher percentage of weight loss than others. A general rule, and there's an exception to this, the higher the percentage of weight loss the surgery is associated with, usually is a little bit more aggressive operation. But if you use your surgery right, it doesn't matter which one you have. You can lose all the weight you need to lose to hit your target. How soon after surgery do I start losing weight? I tell my patients, don't you dare worry that first week, because we put you on a pre-op diet, which causes you to get rid of a lot of water weight. When you have surgery, you retain fluid secondary to surgery for the first week. And so I don't want you to wait until week 2. But we like to see people lose at least 2 pounds a week. We don't really like them losing less than 2 pounds, and we certainly don't like them losing more than 5 pounds, or we start getting a little nervous. The exception to that is the D-switch patients do lose pretty doggone fast. Will insurance cover my procedure? That is a tough question to answer, because insurance has nothing to do with healthcare. Insurance is a contract between either you and an insurance company or your employer and an insurance company. And they negotiate what they will and won't cover. And then if they actually do cover weight loss surgery, and here again, I don't want to be too political, is we should all have coverage for weight loss surgery, because it's one of the most significant health problems in America. The fact that everybody doesn't have a bariatric benefit astonishes me, because we would save so much money if we did. If you're a 3-drug diabetic, your surgery is offset by the cost of your drugs in under 18 months. You're spending more on medicine in 18 months than if you went and had surgery. So we look at each individual. Patient partners can help you with that as well. Do you have a covered benefit? Yes or no? If you have something called a policy exclusion, it doesn't matter how much you weigh, how sick you are, and who you're related to. They have contractually eliminated that from your benefit. Then we have to look at financing options, which there are a lot of, and trying to find the best deal we can for you. If you do have a benefit, they'll say, if medically necessary. How they define that varies from plan to plan, company to company, company to company. That's why you need someone with expertise to help you determine that. Patient partners can help you with that. Our office assigns you someone called an advocate that helps you with that. And then we decide what hoops we have to jump through to satisfy those requirements. We tick off the requirements. We're your advocate. We help you get the coverage.
That was unbelievably insightful. I know there was a ton of questions there, and you were able to just kind of, you had the right answer to every single one of them. And especially that last one, I think is very fascinating, because that's a question that we get asked, quite a bit. And, we can't necessarily answer that. And it's something where, professionals such as yourself has so much more insight. And, some of the nuggets of information that you gave out there, I mean, especially when you correlate the cost of, medication to the cost of surgeries. I mean, it's something that it's very interesting when you put that all into perspective. Once again, I thank you I feel like you've not only guided us through this entire webinar and tackled the misconceptions, you were able to answer all of these questions. And on top of that, share your personal story with everyone here today. If for any reason, maybe you dropped off, or if you want to go back and view this again, the webinar is being recorded. And a copy is going to be sent directly to the email that you signed up with. If you guys are looking to learn more about bariatric surgery, if you want to talk to someone about it, or if you've made that decision to say, hey, I'm ready to make that next step, One, you can always come to patientpartner.com and connect with a patient mentor to have that conversation. You as well can contact Dr. Adam Smith directly. And we will be here for every single step of your healthcare journey. And just across the board, I think, what this shows is the commitment that not only that Dr. Smith has to making sure that patients have the best options, but at the same time, we want to make sure that that you have a partner in your healthcare journey, and that is someone who has already been through it before. So once again, thank you everyone for joining today. Dr. Adam Smith, it's been such a pleasure having you on, and thank you again for sharing all of the information. I know it's been helpful to myself as well as everyone who's joined, and looking forward, not only to working with you in the future, but at the same time, sharing more in our upcoming webinar series.
Thank you for having me. Good luck, everybody.
Thanks, everyone.